So our study looked at overall cesarean rates stratified by parity, which is how many babies you've had, because obviously that has an impact on your risk of cesarean. And we found that the overall cesarean rate from 2012 to 2021 plateaued and even declined, but we noticed striking racial and ethnic disparities, particularly for Black birthing people with higher rates of cesarean birth at the start of the study and an even higher rate, so a widening of that disparity in 2021 at the end of the study period. So we know that cesarean is a really important life-saving surgery. I, as an OBGYN, have done lots and lots of cesarean sections and lots of vaginal deliveries, but it matters for the health of the person giving birth, both in that pregnancy, because it's a major abdominal surgery. So there's increased risk of bleeding, increased risk of infection, but it also matters for someone's lifelong reproductive health, because if you have a C-section with your first birth, you are much more likely to have a C-section with your subsequent births. And your future pregnancies are also at increased risk because of that prior cesarean. There can be increased rates of problems like placenta accreta spectrum, which can be a very serious, even life-threatening diagnosis. So when someone has a C-section in that first birth, it really shapes their whole reproductive life and the risk for their future pregnancies too. It's a great question. Thank you for asking it. I think that C-section is really just a tiny piece of the puzzle as it relates to morbidity and mortality in obstetrics. And we see disparities, racial and ethnic disparities in across the board in obstetrics. And I think we really need to go upstream to address these disparities. We can't just look at C-sections. We have to look at prenatal care. We have to look at preconception care. So the health of people before they're even pregnant. And I think we need to invest in the communities that we're seeing are disproportionately impacted, specifically in the Black birthing community in the United States. When we see disparities like this, it tells me that we need to do a lot of work to invest in that community, and particularly in terms of pregnancy health. And we also have work to do from the clinician workforce side, because I think that an important driver of these disparities is implicit bias and structural racism within the healthcare workforce. That's a lovely question. I think that patient-centered care is really critical when we are talking about a care plan. The patient needs to be in the center of that, as you said, and care needs to be individualized for patients. And for many patients, a C-section will be the right thing, the safest thing. And C-section can be a life-saving intervention when it's necessary. The key, I think, is to make sure that when you're making decisions about something as important as pregnancy and family, that you are centering the patient and you're making a decision that takes into account everything about them. And their race really has nothing to do with whether or not they need a C-section. We know that that doesn't, there's no biological reason for why someone would need a C-section more frequently just because of race and ethnicity. Sure. I think this study is important because what we demonstrated was that the C-section rate did go down across the board in the United States, but this reduction in cesarean rates was not seen for Black people in particular, who had the highest rate of C-section at the start and end of the study period. So what that tells me is that we have a lot of work to do. Um, and I'm excited to keep working on in this area as my work along with my team continues.